very familiar with the various scoring systems which were utilized to determine who needs anticoagulation who has atrial fibrillation. We're familiar with the CHAD study, the CHADS VASC score, the CHADS 2 VASC score, and even the HAS-BLED scoring system. These scoring systems are very helpful to determine who would benefit from anticoagulant therapy. As we all readily appreciate, however, just having an age greater than 70 gets you the point, and 2 points quickly are accumulated in almost all of our dialysis populations. So it turns out that almost all of our dialysis patients with atrial fibrillation, at least by these scoring systems, are indicated to receive anticoagulant therapy. My name is Dr. Robert Albright. I'm one of the consultants in nephrology and hypertension at Mayo Clinic, Rochester. I'm also our division chief. I wanted to thank you for taking a look at this video about an upcoming paper which we have published in the Mayo Clinic Proceedings. The paper is entitled Time and Therapeutic Range for Patients on Warfarin Undergoing Hemodialysis Therapy, a dietary review of vitamin K containing foods. This is extremely important to our clinicians who care for folks with dialysis requiring end-stage renal disease and who also have atrial fibrillation. Over the years, however, it's been apparent that these scoring systems did not include our dialysis population. And in abstract data, which we helped work on in large subsets of patients, we proved that these scoring systems are not necessarily valid in our dialysis population. So with that in the background, we also understand that we don't want our patients suffering the devastating consequences of a stroke. But on the contralateral side, the risk of bleeding exceeds the risk of a stroke in the majority of dialysis patients, as published by multiple authors. There's a legitimate question even about whether anticoagulation is indicated for all the patients who suffer end-stage renal disease on hemodialysis. As we reviewed this topic, we recognized that perhaps we even needed to take a step further back. It's important to recognize the life of a dialysis patient. Dialysis patients are on treatment for the better part of 12 hours a week. They come to a center, they're often treated in center, and although we're trying to accelerate our outpatient home dialysis population, still the majority of patients in our population are treated in center for their dialysis requirements. This provides a tremendous barrier as many patients are cared for in proprietary dialysis units whose care systems are outside of usual Warfarin clinics or Coumadin clinics as they're called. The integration, therefore, of data is very difficult. Even checking the levels can be difficult because even when the levels are checked in proprietary systems, it can be legitimately 48 to 72 hours until the results are back. Expecting a patient to go to a Coumadin clinic after dialysis can be a very difficult burden for our patients. We would also understand the practicalities in a dialysis population of integrating the prescription of antibiotic therapy, other agents which may impact their anticoagulants, and the impact of the anticoagulant itself often used during dialysis. All these pose a very basic question which needed to be answered, and that is, how much time do patients actually spend in therapeutic range when we do prescribe, for good reasons, warfarin-based anticoagulation? Well, this study helped to address that. Additionally, this study then did an intervention to try to look at whether we could use our integrated health system and improve the amount of time our patients who required anticoagulant therapy were within therapeutic range. So back to the first question. Over the period of time from 2010 to 2018, using 187 patients who allowed us to use their data and agreed to this retrospective study initially, the entire cohort had a very disappointing 44% of their time within therapeutic range. Now again, I'll highlight here at Mayo Clinic, we're extremely fortunate to have our own dialysis units with our own integrated care team, the care team including the usual dialysis care team, including a registered dietitian, but also a pharmacist to help us integrate the medications we prescribe and at the same time help keep our patients within therapeutic range. Our patients are all kept within one electronic health record, and again, one healthcare team takes care of them, with stable membership as well. So even in what one could argue is an optimal clinical setting, we only achieved time in therapeutic range of 44%. Very disappointing. We then took one step further and decided, what if we intensely educated our patients about vitamin K containing foods, educated them about the impact of their other medications, and provided both verbal as well as written and graphical reinforcement. So that's what we did for our patients. We studied how well they had done from the perspective of their time in therapeutic range prior to the intervention and then afterwards. Unfortunately, we did not see a tremendous benefit. If we looked at the time of INRs greater than 5, a sentinel event, there was no difference in our intervention group. Fortunately, those events were very rare, only occurring once. However, if we looked at our folks whose INR was less than 1.5, subtherapeutic, there was not a tremendous benefit pre or post-intervention. One bright spot was that if we looked at our median time of patients within therapeutic range, there was a slight benefit for patients in the intervention group whose INR was less than 1.5. In plain English, what we saw was there was a slight improvement that was statistically significant in our intervention group of patients not having an INR below 1.5. I believe what this study highlights is that we need to go back to basics. We're all very interested in moving the field ahead in perhaps applying direct-acting anticoagulants for our population, as they've been shown to be equivalent to warfarin. But I think we need to step back and understand that there are several barriers at play, and we need to provide patient-centric research as we go forward. And what I mean by that is our major opportunity is to even study whether the drug is in the patient's system, whether that be a direct anticoagulant or their INR, and acknowledge the tremendous barriers that our dialysis population has to navigate every day. I believe this study will highlight to future investigators, starting from ground zero and making sure that we understand all the barriers of the mechanisms of how a patient even utilizes their anticoagulant therapy. I think it also offers us the opportunity to explore whether we should change our approach entirely and even engage other perhaps occlusive devices for the left atrium as a way forward. But again, if we were going to compare that device to medical therapy, it would be important to understand how well the anticoagulant therapy worked itself. My thanks for your attention. I hope you enjoy the article.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.